Hello anatomy colleagues, this is Dr. Alsup, and in this learning objective video we will be discussing the hip joint. So I'm guessing you have a pretty good idea where the hip joint is actually located, so we will spend the majority of our time discussing some of the major accessory structures, including ligaments and tendons. As always, we will discuss the movements possible at the hip joint and any other pertinent clinical information in this area. The hip joint is the other major ball and socket joint, and because of this, it's one of the most mobile joints in the body. In fact, it is the second most mobile joint in the body, second to the glenohumeral or the shoulder joint. Now, it is kind of the exception to the rule that mobility means decreased stability, as the hip joint is a very stable joint, which makes sense if you think about the amount of weight that is moving through the body through the hip joint, and of course what needs to occur with locomotion. You need a lot of stability here with a fair share of mobility. The stability is very dependent on a variety of things, such as accessory structures, which we will talk about in a moment, but it also has to do with the fit of the articulating bones. And so you have this relatively deep socket, which is the acetabulum of the coxal bone, and that is going to allow the fit of this large head of the femur. So those are the two articulating bones. There are so many accessory structures associated with the hip joint. We could spend half of your curriculum here, but alas, we cannot. So I'm going to focus on three representatives in this area that play a major role in stability and protection. The first is the acetabular labrum. And I hope you recall back in our first discussions of synovial joints that labra are associated with ball and socket joints. And so, of course, we will find a fibrocartilaginous lip associated with this area, so with the acetabulum here. So you can see a bit of it right here, you can see a bit of it right here. And this provides an additional component of strong fit between the acetabulum and the head of the femur. Additionally, there are numerous ligaments associated with the hip joint, as you can see in the images here. But the largest and most dominant one is the iliofemoral ligament. You can see it labeled here. It's making up the bulk of this region here. This is the largest and most dominant. It is sometimes referred to as the Y ligament based on its so-called shape. In some literature or textbooks, you hear this referred to as the strongest ligament of the body. I am not quite positive that that is true, but it is certainly among the top 5 list, and it is most certainly the most prominent ligament in this hip joint. It is more anteriorly placed, extending between the ilium, so here's the ilium and the femur. And even though it's more anteriorly placed, even if you're looking at a posterior view, which you can see here, you can see a bit of the iliofemoral ligament as well. Other than, of course, providing overall stability and protection of the joint, the iliofemoral ligament also specifically prevents hyperextension, so extension past where it should, of the hip joint, so both during active movement as well as during standing. It really serves to prevent hyperextension. So that's important in terms of stance phase as well as in terms of locomotion. Ligaments aren't the only protectors in this area. Tendons and muscle bellies play a huge role as well, specifically the medial and lateral rotators of the hip joint. So those are really closely associated and closely located with the hip joint. And we will be discussing those in upcoming learning objectives. The hip joint is capable of all actions that a ball and socket joint can do, which is all the actions really that a synovial joint can do. So you can have flexion and extension. So think flexion is moving the thigh anteriorly in the sagittal plane with extension moving it back. Abduction, you're going to have moving away from the body, as you can see here in that coronal plane, and adduction is moving back. And you put those 4 movements together and you can have circumduction of the hip joint. Recall also that ball and socket joints are also capable of rotation with medial or internal rotation and lateral or external rotation. Before we finish our conversation on the hip joint, I do want to focus in on one critical consideration, which are fractured hips. Fractured hips are rarely fractures to the coxal bones, but instead typically a fracture of the proximal femur. And one of the most common areas for fracture is the neck. So this right here is the neck of the femur. And as you can see, there are numerous types of neck fractures that can occur. And by the way, I don't want you to memorize this image in terms of the specifics here. I just kind of have it here more in terms of telling you or showing you the types of fractures that can occur. Femoral neck fractures are most common in older individuals, particularly those that also have osteoporosis. And what's important here, other than the fact that, of course, it's a fracture in this region, can certainly affect hip motions, it's also that these fractures often disrupt blood supply. So there's smaller retinacular arteries from the medial circumflex femoral artery. If these are disrupted, you're left with a pretty weak blood supply. There's a little branch traveling in this ligament right here, the ligament of the head of the femur, but it's typically not sufficient or is inadequate for maintaining the femoral head's blood supply, so this area may undergo avascular necrosis without intervention. Excellent. We have reached the summary slide. Please take time to review, and as always, please reach out if you have any questions. Thank you for your time and attention, and have a great rest of your day.